All right. Well, good morning, everybody. I'm Mayor Greg Fisher. Thanks for joining us here today. We've got a big announcement and some exciting news to share from our partners at the University of Louisville. Before we get into that, we're going to take a quick look at today's data as it relates to COVID-19 and all the challenges that are associated with that. As of today here in Louisville, we've had 5,456 COVID-19 reported cases and 231 deaths. That's 97 new cases. Thankfully, no additional deaths since yesterday in the past few days. Our positivity rate is still bouncing around that 6.67% range. Again, a note on that, we don't have all of the tests that were negative, so the actual positivity rate would be lower. If we had those, we're working with the state to try to get better information in that area. We've tested about 81,789 people in our city so far. And of the 5,456 who've tested positive, 3,874 have recovered. This number is obviously growing. We're seeing not just growth here in Louisville, but we're seeing very significant growth from the south into the southwest of us. Florida, Georgia, Texas, Arizona, California are having massive spread right now. We went into our stay at home a little bit earlier. We came out later. We put our mask on earlier as well. So we pray that we don't have that type of increase, although these last 3 weeks, we're seeing increase of 30 to 40% week over week. And that's what this virus does when it spreads very exponentially. So it's really important that we all continue to do what we know we need to do to slow the spread of this virus. Wear your mask, please. Put a face covering on. Governor has mandated that statewide. We have heavy support for that here in Louisville. We're seeing better compliance as you go out to the large retail stores. So always have your mask with you, and obviously keep doing your social distancing as well. We'll very much control our future, and the sooner that we have compliance and the numbers are going down, sooner the kids can get back to school, sooner we can have ball games, all the kind of things that we want to get back to. So we're making, we know what it is that we need to do. First responders, just a brief update on that as well. We have no new positive tests today. Overall, 69 Louisville first responders have tested positive. 62 of them are now back at work and at Metro Corrections. 2,221 inmates have been tested since the outbreak began, and we've seen 36 positive tests. All right, so main message from the city, wear your mask, stay socially distant, don't go out if you want. We're seeing an increase here, so please do your part to make sure that it does not continue to increase so we can control this. Now, for the main purpose of today, let's talk about the University of Louisville and the great work that they're doing. I'm happy to be joined by some special guests from the University of Louisville. Our city is really blessed with outstanding scientists and scholars who are deeply invested in the health of our community. They have been for a long time, and they're rising to the occasion again here with our COVID crisis. We've also been seeing groundbreaking work by University of Louisville in efforts like the Green Heart Project, which is part of the groundbreaking work in the emerging field of environmental medicine that's happening at the University of Louisville Christina Lee Brown Envirome Institute. Now, in April, in cooperation with the Louisville Healthcare CEO Council, this brilliant group of U of L scientists launched the Co-Immunity Project as part of the efforts to fight COVID-19. And today, they're going to share some of the results of their work. So I'd like to welcome Dr. Aruni Bhatnagar. He's the director of the University of Louisville Brown Envirome Institute. Dr. Rachel Keith is the assistant professor of environmental medicine at U of L, director of human subject research at the Brown Envirome Institute. Dr. Kenneth Palmer is the director of the U of L Center for Predictive Medicine for Biodefense and Emerging Infectious Diseases. And Dr. John Klein, an old friend in my Saturday morning town hall co-host for That Doctor Is In. Dr. Klein is also the vice dean for research at the University of Louisville School of Medicine. So Dr. Bhatnagar will kick it off from here. Welcome to the U of L team, Dr. Bhatnagar.
Thank you, Mayor Fisher, and thank you for this opportunity to share our work with you and for the rest of the people in the city. We're very excited about this set of data and the results that we've gotten. We've been working on this for a very long time. As you mentioned, the Co-Immunity Project was launched, I think, way back in April. And last month, we announced the initial, which is called the phase one of the co-immunity project, our results with the healthcare workers. We thought that that was the first and the most important thing to do. Now, in the last month, and from June 10th to the 19th, we've been busy conducting the phase two of the co-immunity project, which is to test the members of the Metro Louisville community, both for the presence of the coronavirus by swapping in the nasal passages and for antibodies against the virus in their blood, so that we would know who has the disease that at that particular time and who has had the disease since the beginning of the pandemic. So there are lots of different trials and samples and tests around the city. But our study, because we're from the university, has to do with collecting data that will tell us better than any other way who in the city has had or has been exposed to the virus, who has infection, and where they live, and so on. So we wanted to do a sort of a randomized sample of the population. And we collected these samples at 5 different drive-up locations from June 10th to June 19th. And this was these sites were organized by the University of Louisville Health and researchers from our Enviro institutes. We collected the samples and then they were analyzed by the Center of Predictive Medicine for Biodefense and Emerging Infectious Disease at U of L's Regional Biocontainment Laboratory. To get a representative sample of the study, we sampled households in Jefferson County and then organized these households into different geographic regions based on the US Census Bureau tract boundaries. And then households within each region were sent an invitation to participate. And within these regions, area that a higher concentration of non-white residents was sampled at a higher rate to increase their representation. We sent out, I think, a total of about 18,000 invitations to participate in the study. And then based on the age and the sex of all the adults in the household, we sampled one adult to, or we invited them to come for testing. So as a result of this activity, we tested about 500 people who responded to the mail invitation. And then since we did not get large enough samples, we recruited another 1,700 community members who booked their own appointments and they were tested for both the virus and the antibodies. Of these who were tested, about 10% were non-whites and about 40% were within the ages about 35 to 60 and about 40% were 60 years older and the rest were under the age of 34. So if I can show you the first map, which shows the residential location of all the participants in the study. And we have two sets of participants, one who responded to the invitation and the others who volunteered for the testing. I don't know if you can see the map or not, but the map shows that that we have generally a very wide and uniform coverage of the entire county, and we sampled nearly 0.4% of the population. And once we collected the data, from these samples, we adjusted it according to correspond to the population characteristics of the area of that county. After analysis, we found that at least 0.05% of our participants had an active infection during the time of the study, and nearly 4% of the people had sort of measurable levels of antibodies in their blood, indicating that they have been exposed to the virus sometimes during this year. So these results are important because they, for the first time, give us a sort of an accurate picture of how widespread the viral infection is within a community or has been in the community. And if we can sort of extrapolate these results to the general population, it will suggest that as many as 20,000 people have been exposed to the virus starting in late January. This is much, much higher than the 3,800 cases that we reported, the city reported by the end of June. So this provides a handle on where we are in terms of the epidemic of the pandemic. And I think these data are in fact much more sort of rigorous and believable and accurate than the estimates that we have from any other random sampling, any other convenience sampling around, even around the world. So this sort of data would then is important because it will tell us what the actual mortality may be. So we know that during the time about 209 people succumbed to the disease by the end of June. So we would estimate that the overall mortality rate of COVID-19 is about 1.3%. So this is much higher than what's been estimated before, which is about 0.6%, but also in some sense lower from other estimates. So we believe that we now have a firm grasp on how deadly this particular disease may be. But we do not yet know enough about this disease, so I think we will continue to keep working on it. We will do another survey in September, and then we will pool all the data together so that we can not only identify who is being infected, where they live, and what the trajectory of this virus has been in our community. So I'm going to end here, but I want to thank all the people who have supported our studies. We had support from the James Graham Brown Foundation. We had support from the Owsley Brown Family Foundation, as well as from the Jewish Heritage Foundation Fund for Excellence. And because of this generous support, that we could do this work, which is part of our larger co-immunity project. So I'm going to stop here, and then I'm going to hand over to my colleague Rachel Keith. As you pointed out, she is an assistant professor in the department, and she's the one who actually did all the work. So Rachel?
Thank you, Dr. Bhatnagar. Yes, so we were able to put on this co-immunity project with the help of U of L Health. We went to 5 separate drive-in locations that were scattered throughout the community. We believe that by this random sampling and reaching out to the entire Jefferson County, that we were able to pull in participants from all geographic areas in Louisville and Jefferson County, strengthening our data. So in order to allow those people to come in, we also set up mobile and had sites for testing throughout all of Jefferson County. Dr. Bhatnagar mentioned we had a low positivity rate for active infections, but that our antibodies were higher, showing a higher percentage of people that may have been infected, somewhere around 4%. This is likely because many people don't have symptoms of the virus while they're having it, and or we had multiple people reporting to us that they believe that they had the infection in March when testing was not as widely available. So this really allows us to do a better estimate by using antibodies of who may have had it in the past, and understand who to date could have been positive. So it also shows us that this virus may have been more widespread in our community than we originally thought, which indicates, and I believe, that we need continued testing and we need widespread testing, and that there is a utility to antibody testing to understand the spread of the disease. We also think that because the participants are drawn from all parts of the city, we have a much more accurate representation of the spread of the infection, which can also allow us to start to look at where infection is highest. If you're able to pull up map 2, that would be helpful. You can see we have our highest rates of infection in the area of West Louisville. It is much higher than other parts of the city, and the highest clusters of, it would represent the highest clusters of people exposed. So we believe that the prevalence of exposure is twice as high in our non-white participants as our white participants as well, and that most of the participants who tested positive for the antibodies were between the ages of 35 and 59. So we do also want to reiterate that the results of the survey were from June 10th through June 19th. And so this data and this information we're presenting today is applicable to that time, and that we know that the virus changes and the spread may be changing over time. So continuing to do the testing will allow us to look at that as well. But even though I suggested that antibody testing is very useful, I like it for tracking the disease and prevalence. We have an expert here, Dr. Kenneth Palmer, who can talk to us more about what antibodies mean and antibody testing, and provide us more information on that.
Thank you, Dr. Keith, for the introduction. The way that we performed the antibody testing was we received blood samples from all of the community participants, and I'd like to reiterate my thanks to all the volunteers who provided samples for our research. We really couldn't have done this research without you. We separated the blood cells from the blood plasma and measured the amount of antibodies that bind to the SARS coronavirus virus spike protein. Many of you have seen a model of the virus with this corona of spikes around on the surface of the virus. And what we were looking for were antibodies, specifically immunoglobulin G antibodies, that bound to the spike protein of SARS coronavirus. When we identified SARS coronavirus 2, that is, when we identified people who had antibodies, who were seropositive, we then investigated further to understand the nature of the antibody response. We looked at whether these people had immunoglobulin G, IgG, IgA, and IgM that recognized the spike protein. And then we also looked to see whether these people have antibodies that recognize the receptor binding domain on the spike protein. This is a small part of the spike protein that is responsible for the interaction between the virus and the cell receptor that it uses to get into the cell. The idea is that people who have antibodies that recognize the receptor binding domain will have antibodies that stop the virus from getting into the cell. And so we work to characterize the number of people who were infected, and then also to look at the number of people who had antibodies that recognized the receptor binding domain. And that allowed us to build a picture really of what the prevalence of SARS coronavirus 2 infection was in Louisville prior to the sampling period. And as the speakers who have spoken before mentioned, it looks like at that time point we have about 4% of the population that have antibodies to the SARS coronavirus spike. We look forward to working with community volunteers in our next sampling round so that when we next are able to measure the prevalence of antibodies in this population, we'll be able to understand what has changed between the sampling period in June and the next sampling period. This is an ongoing research project that we hope is helpful to everybody who wants to understand the nature of the SARS coronavirus 2 pandemic here in Louisville. With that said, I would like to turn over to my colleague, Dr. John Klein, the Vice Dean for Research in the University of Louisville School of Medicine. Thank you.
Thanks, Dr. Palmer. So where do we go from here? The community project will continue, and we think that it will continue through several more cycles of analysis. As you heard already, phase 1 is the study of healthcare workers in the city We just finished the most recent round of healthcare worker studies last week, and we'll announce the results next week as well. Then the community phase 2, which is what we've been discussing this morning, will be repeated. Approximately September 9th will be the kickoff of the next round of community 2. These are really essential studies that allow both university scholars as well as policymakers to understand the extent of the infection in two populations. One is the population as a whole, the city at large, but the other is also among healthcare workers. And as we've said many, many times, the protection of the healthcare system and to keep it built up so that it can withstand stress is an important part of what these studies are about. We expect these studies to continue, and at the university is very strongly dedicated to supporting this study. And we're also, as has been said before, very grateful to the donations from the Jewish Heritage Fund for Excellence, which supports our healthcare worker study, then the James Graham Brown Foundation, which is supporting the ongoing general population studies, and then also from the Owsley Brown Family Foundation, which is supporting these studies, as well as our wastewater study, which is testing for the virus in wastewater in the city. And there'll be more about that we'll be making public in the coming weeks. And with that, I'll turn this back over to Dr. Bhatnagar and let him wrap things up for us.
Thank you, John, and everyone who could be here. And I'm just going to close and hand it over to Mayor Fisher. So this is what, Mayor, we've been doing. We think that there is much more work that needs to be done. We think that we should be doing widespread testing, and that is exactly what a plan is for the next time. And we will keep doing this if we have enough support. Every 8 weeks that we will keep testing for the community participants, and every 6 weeks for healthcare workers, and so that we will have a sort of a continuous grip, and we maintain a surveillance of what's happening to our community. So if things change rapidly, we can inform you of what is happening and where it is happening.
All right, thank you, Dr. Bhatnagar. Let's see, we've been having some WebEx challenges. So are you finished, Doc?
Yes.
Just give me a thumbs up. Okay. Got a couple questions for you from the media that I'll throw back to you. First one, Amin Elahi from WFPL has a couple questions, and first is, can you please explain in detail how you calculate the positivity rate?
So we sample people from all around the town, and then we actually calculate the amount, the probability of their being selected in the sample, and then we adjust for how representative they are of the different populations, or the different mix of the population in the area of Jefferson County. So this is a usual sampling procedure, which is a statistical adjustment for sort of considering that we have equal and proportional representation of age, race, and sex.
Thank you. And can you comment on the accuracy of commercial antibody tests versus what you all are doing?
So I would like Dr. Palmer to comment on that, because he has his own views about that. I think those are what we have been following.
Thank you for that question, Dr. Bhatnagar. We haven't assessed the accuracy of commercial antibody tests. What we did is we developed our own immunoassay, which is called an enzyme-linked immunosorbent assay, or an ELISA. And we validated the assay for sensitivity and specificity based on samples from known positives and known negatives. And many of the negatives would have come from prior to the COVID-19 pandemic to verify that those were negative. So we are very comfortable that our assay is highly specific and highly sensitive. And I really can't comment on specific commercial antibody assays. I certainly know from the media that there have been some significant variability in the performance of some of the commercial antibody tests. Our antibody test is performed in our laboratory by expert technicians, and we have validated the sensitivity and specificity of our assay.
I guess, Dr. Palmer, this question probably relates to that. The University of Kentucky Hospital recently ran into a problem with false positives resulting from a software glitch. Is that a concern for something like that with the U of L study, and is that a possibility?
We believe it's not a possibility for the whole study because our assay is qualified and validated and run with extensive quality control and quality assurance oversight. Of course, you can't predict system failures, but I would say that our laboratory functions under very strict quality control and quality assurance oversight.
Thank you. Dr. Bhatnagar from, again, WFPL, Amin Alahi. This study shows that many more people were exposed than previously known. Do city officials still recommend prioritizing testing for symptomatic people or those with known exposures? And doesn't what these results released today suggest we should be testing more broadly? So why don't you give your view on that? Obviously, we would like to have unlimited testing capacity, but what's your observations, Dr. Bhatnagar?
Yes, I would agree. It depends upon our capabilities and capacities. I think that it is many of the people who are exposed to the virus don't know it. They don't have symptoms or have very mild symptoms, but they can still transmit the virus. So in order to get a very firm grip, we have to know who is actually infected regardless of symptoms. So that's why we did this whole study, to be able to identify those individuals. And even then, we do not have the resources to test everybody all the time, but certainly people who have the disease or who have symptoms should be prioritized because they need to promptly start treatment and be isolated. But there should be enough capacity to test people who are suspected of having the disease, and certainly would be beneficial to have very wide testing.
Thank you for that. So I'm sensitive to U of L's time lot here to end at 11 o'clock. One of the questions that came in is, can the copies of these maps or images be available? And the copies of the maps per Betty Kaufman at U of L are in the news release and also available separately. Any questions can be emailed to her at betty.kaufman, C-O-F-F-M-A-N, at louisville.edu. With that, Dr. Bhatnagar, any closing remarks from you?
No, thank you very much. And I think we will continue to keep working together, and we'll occasionally come back and provide you with more information as the results become available.
Well, we're extraordinarily grateful for the wonderful scholars that you have at the University of Louisville and your leadership in this area, whether it's Green Heart or now with the COVID virus. We know we can always count on U of L. So I want to say thank you once again to the University of Louisville team for joining us to announce the results of the phase 2 of the Co-Immunity Project. Go Cards, keep her going. We'll get through this. Thank you for the University of Louisville, and we'll stay on and answer a few other questions. But thanks, U of L. If you want to stay on, great, but I know you had an 11 o'clock stop as well. So
all right, thank you.
Thank you all.
Bye.
All right, let's go with either Bill Altman or Sarah Moyer. Dr. Moyer, obviously, is our chief health strategist. Bill Altman, I think, is on the call here. He's leading our testing efforts to get their observations on the presentation from the University of Louisville and what it means for us here in Louisville. Dr. Moyer?
Thanks, Mayor. Not sure if video or anything's working, but good morning, everyone. No, this is just, I'm really excited about the partnership with U of L and the data that they released today. I think it definitely shows we had more COVID than we had tests available back in March. And so just great to see what areas of our community were hardest hit when majority of us were able to stay home and had the privilege to work from home when we were exposed less. But we know that some essential workers were still out in the community and still were exposed more. And so I think that was really highlighted in the maps that they showed and what areas of our community that we knew were probably hardest hit. So great to see that, and just looking forward to see how that changes when they do their September testing as well. So like I said, I'll turn it over to Bill to see just what else he had to add to it.
Okay. Bill Altman.
Yeah, just a couple of things that I would add. First of all, I think what I'm most excited about in terms of this research project and these initial results is what it looks like over time. I think that's going to be incredibly helpful to the community and to the policymakers to see what the trends are, both in terms of how many people are testing positive pursuant to this sophisticated sampling methodology so that we can extrapolate those results to the community, and also the trend line in terms of how many people have been exposed through the antibody testing, which is also going to give us valuable information. The second thing I would say, just in terms of the implications of this research for the purposes of what it says to the community, is the fact that the antibody testing showed that more people in the community had the virus than we previously knew about, and many of these people were asymptomatic. It reinforces the message that we've been delivering throughout this pandemic, which is that we can't assume that people who aren't symptomatic are not carrying the disease. And therefore, the implications are we have to take the precautions that we've been reinforcing. Everyone needs to wear masks. Everyone needs to social distance. Everyone needs to wash hands and reduce our level of activity out in the community and just be very mindful of that. That is the key community takeaway to me from this research.
Thank you, Bill. And do you want to give a description of where testing is taking place right now and volume-wise, how we're looking there?
Yeah, so first of all, in terms of what options exist in the community for testing, encourage everyone to go to the Department of Public Health and Wellness website that is updated basically daily in terms of the testing sites that are available. Look, I think it's everyone is aware of the fact that the testing resources are being strained right now. It's strained as a result of the uptick in cases. It's strained as a result of people who may have engaged in activities that cause them concern, and so they're seeking out testing. So as a result, the testing task force that we have convened of the local hospital systems, community health centers, others, are looking at ways to continue to expand testing capacity. So if you go to the website, you'll notice, for example, the Norton Audubon site has expanded its hours significantly. There are new sites that are opening up. Family Health Centers has opened up a couple of sites and expanded their hours. And we're exploring every single option of providing more testing services to the community in areas where we know it's needed. I would mention, Mayor, that there's a very large event that's happening this Sunday on the South End, sponsored by a number of community groups, Family Health Centers, Blue Water Lab, targeted specifically at the Hispanic population. And you can find out the details of that event. That has a lot of capacity for testing. All of these things are occurring because we recognize the need for expanded testing services. And there's also delays in getting the testing results back when these results are sent to the national labs. And that's as a result of the crises that exist in Florida, Texas, California, Arizona, and elsewhere, because those national labs are being tapped in terms of their capacity. So we're also exploring a lot of different options to reduce the amount of time that it takes to get testing results back. And you know, more on that to follow, but you know, we're everyone in the community, all of the providers, the labs, the community health centers are working together to expand the number of tests that are made available to the community.
And can you share, Bill, explain what the pooled testing is? We're starting to read about that in the last week or so. And are any of the labs starting to use that, or are we in the early phase? So what is it and what's the status?
Yeah, and if there's anyone from the U of L team, you know, Dr. Palmer might be, and Dr. Klein and others might be in the best position to explain it from a a scientific perspective, but from a lay perspective, the notion is that there's a technology emerging that allows one to take a number of samples that have been tested, a number of individual tests, and run them together to get a result that says for this group of patients, is there no positivity, in which case you can move on, or is there positivity, and then there are ways to redo the test to identify individuals. And it's early. I would characterize it as early, but the University of Louisville, I know, is one of the few, if only local labs that really does have that ability, and think of it in terms of being very useful for more broad scale surveillance as opposed to individual testings, because the reality is these diagnostic tests are not set up for widespread community testing. It's an individual diagnostic test. But I see that Dr. Palmer, Dr. Klein are still on. They might want to add the specifics about what pool testing is and its potential utility in terms of community surveillance.
Dr. Klein?
I was going to turn that one over to Ken Palmer, but he's not logging on, so I'll take a crack at it. So it's exactly like Mr. Altman said. If you look at the way the test is run in most laboratories, it's run in a plastic tray that has 96 wells. Looks sort of like a checkerboard. And normally we would put one patient in each well. Instead, what we can do is take the entire row of samples, so 16 individuals, for example, and go ahead and put them all into one sample. And if it's negative, we know all 16 of those people are negative. If it's positive, then we have to ask the question of, do we go back and try and find the 1, 2, or 3 people who are positive, or do we simply use that information based on where the location of the donors were to take some sort of action? In most instances, people think that this is just a very fast way to screen through a large number of samples by pooling them together and then pick out the ones that are individually positive by going back and retesting. And there are a couple little tricks that we can do in the lab to make that more efficient than it sounds. So it is a good way to cover a lot of ground in terms of testing and larger numbers of people. It's one that we've talked about. Dr. Palmer and his team have been talking about this literally since March, but we only have approval from the federal government just this last week to really begin doing it. And so we'll have to see where that takes us.
Thank you. Dr. Moore, there's a question from you from Paul Miles. Can you speak to some of the reasons the study shows the highest cluster of COVID exposures in Western Louisville?
Yeah, so mentioned that in the beginning. I mean, we know that back in March, April, May, when a majority of our city was able to be at home and practicing the social distancing and everything recommended, a higher percentage of people from those neighborhoods were the ones in essential jobs and working. And so that would be my best educated guess and why those numbers are higher. I believe T. Gonzalez, our director for the Center for Health Equity, is on and can maybe provide some more insight into that.
Okay. T?
Maybe he's not on.
Okay.
But,
all right.
But yeah, so it's expected. I mean, it's based off of what, if you look at our health equity report, those are the same numbers that have higher rates of a lot of health outcomes in our community. And so why we have the testing task force and why we're focusing efforts on our neighborhoods and zip codes that don't have the ability to make the choices that some of us in the city can.
Right. All right. Well, that's our final question. So thanks everybody for joining us today. Again, the message is out there that the virus continues to increase at a scale that we're very concerned about. The question is it going to continue to increase like it has these last 3 weeks, week over week?